Good morning and welcome to Psychological Professions Week 2021. Thank you very much for bearing with us. And apologies, we're getting underway just a couple of minutes late. So you're very welcome here. If you're a practitioner, if you're a member of the public, if you're a policymaker, and thank you to all involved in making this week happen, including the conference steering group. We're delighted to have over 3,000 people signed up to take part in the week. And we've got a fantastic week ahead. So we have a focus on children and young people's mental health in the pandemic and what we can do to help. We will be looking at innovations in low intensity ways of working, applying psychological practice across the whole of health and care, how outcome measurement can make a difference to the public, the innovations that are happening around new roles in the psychological professions, actions around equality, diversity and inclusion, progress being made by the psychological professions networks in each region, and how to take up a career in the psychological professions, and finishing the week off on Friday with how we might all take up leadership, whatever our role in the system. So we really hope you'll be able to join us for as many of these sessions as you're able to, as many of these workshops as you can. And today we'll be getting underway in a moment with the first of the workshops, which is about shared decision making. So at the moment, the NHS is under considerable pressure, as we all know. At a time like this, we need a psychological approach more than ever. We need it more than ever because psychological knowledge can help us to adapt in difficult times as well as in good times. And psychological practice can ensure that we keep kindness and excellent communication at the heart of what we're doing. So we need to press on and expand the psychological professions workforce, to expand psychological healthcare. We need to also work differently to make the biggest impact that we possibly can for the public. And to achieve this, we believe really strongly that we're going to need to work in partnership across the 12 plus psychological professions and other occupations with an interest in psychological practice, partnership with the public, and partnership with policymakers. The Psychological Professions Network, which is a free membership network commissioned by Health Education England, builds these bridges between the professions, the public and policymakers. And so this week, we think we'll be able to together cement those bridges further, continue to build them so that we can make the maximum possible impact of the psychological professions for the public. So I'm just going to run through a few housekeeping notes now. We'd love to hear from you during the session today and during the conference. So you'll see down the right-hand side of your screen a window that allows you to type in questions or comments, and these will be sort of passed through to the presenting team so that we can pick up as many as we can of those towards the end of the session. You can also vote on those questions if you once they're published, if you're particularly interested in that one, and so we'll be able to see where the greatest interest lies. If you do have any technical issues, there's an email address here that you can seek some support from during the session. We are going to be recording the session, so if you do want to post into the Slido window on the right-hand side, but don't want your name to appear, please do that anonymously. And at the end of the session, we'll be saying a bit more about where you can access all of the materials after today and how to download your attendance certificate. So we really hope you enjoy the session. I'm going to hand over now to my co-chair for this morning, Laura Lee, who's going to introduce the session today.
Good morning. My name's Laura Lee. I'm an expert by experience, and I'm national lead for expert by experience involvement for the psychological professions. And this session is about involving us, the power of shared decision making. And we're welcoming to the session Adrian, myself, Nick Gray, Rachel Terry, and Paul and Jeff, who are experts by experience. So our session is going to run for just over an hour and 5 minutes, and you can see there on the screen the things that are included in the session. We're starting with a couple of videos, so I'm just going to hand back for our first video.
We know. You've seen many a vision come and go. We're trying to do something different here. In 2020, we went on a journey to co-create a more impactful and unified future for the 12 psychological professions so that we can deliver the best possible care and support for everyone in our communities. We had over 1,800 people coming together to share over 12,000 ideas, comments and votes about our vision for the future of the psychological professions and the commitments we must all make to achieve our visionary goals. A vision for the psychological professions. To transform lives and communities by extending and embedding psychological knowledge and practice across the whole of health and care. Here are just some of the commitments. Put people first. Work in genuine partnership with service users, carers, and families to understand their needs and to design and deliver services that meet these needs. Empower people to improve their psychological health and well-being by sharing and communicating psychological knowledge. Support the psychological well-being of colleagues working in health and care services in good times and in bad. Now, we want to make this vision real. We want to bring it down from these visionary planets to our blue and green planet Earth and connect it with everyday life. We are calling this process the Intergalactic Bridge. Over the next few months, join us in creating the Intergalactic Bridge. Tell us what's been working for you and your ideas on how to make this real. We'd love to hear from you.
Thank you very much. So you'll see across the morning sessions this week that each of the sessions is themed around the psychological professions vision, and today our vision commitment to put people first. So over to you, Laura.
Could you move on to the next slide, please? So our session this morning is based on the National Institute for Healthcare Excellence, NICE, guidance on shared decision making, which was published in June 21st. You can see here the link. But before we get into the more details about that, we have another video. So let's set up for the next video.
Evidence-based practice is a commonly used term, but what does it really mean? It's when research evidence, informed patient choice, and clinical expertise all come together. Research tells us psychological approaches that are likely to work. Evidence is drawn from different types of research. Research is used by expert groups of clinicians and patients, such as the National Institute for Health and Care Excellence, to recommend which talking therapies to use. Research evidence means we know which psychological therapies and other interventions are most likely to be effective.
It's vital people are involved in decisions about their care. Shared decision-making has been proven to enhance the success of psychological approaches. It means the person's culture, values and preferences can be considered, and psychological approaches can be tailored to specific needs. Only when someone has been given all the information, when they've heard the evidence and its limitations, and when they can be sure that their goals, values and preferences have been considered, that they can truly give their full consent. The final piece of the puzzle is clinical expertise. Psychological interventions happen in unique situations, and research evidence and patient choice aren't always enough to guide a decision. Clinicians need to use their expertise and experience to shape and adapt psychological approaches to respond to individual and cultural needs. By regularly reviewing progress and outcomes, professionals can work with people to make sure psychological approaches are as effective as possible.
Each component of evidence-based practice is important. By focusing on all three, psychological professionals can ensure people's needs and choices are met. And working in partnership with the public means people will receive the most meaningful and effective service.
Could we go to the next slide, please? And I think we want to introduce Dr. Nick Gray, who's going to speak next. So can I hand over to Nick?
Great, thank you, Laura, and thank you for inviting me to talk. I'm going to just say a little bit about shared decision making in the context of this video for the psychological professions, and also just setting a little bit of context for some more that's to come in this symposium. The thing that really wanting to kind of highlight is the kind of that patient choice, and that patient choice really is the kind of the glue, the cement in the kind of the middle of evidence-based practice. And this is the thing that we're really wanting to help us kind of sort of focus on in this symposium. And NICE, as kind of Laura kind of mentioned, has recently actually tried to kind of look at this kind of systematically across healthcare, and there are new guidance around shared decision making, which will be described a little bit kind of later in this kind of symposium. However, what I'm aware of from kind of talking with many kind of clinicians and others is that there are kind of yes buts that arise when thinking about kind of sort of shared decision making, that kind of people kind of would say, well, perhaps kind of patients don't want to be involved. Kind of my kind of clients say, my service users say, well, look, you know best, what would you do? And certainly if people are saying that kind of initially, it may be that they don't have the confidence to speak up or think about what they want or how much involvement that they need. And what our job is as kind of working in healthcare and as psychological professions is really helping people gain that confidence and support them in kind of making those decisions. And when people are still asking for our kind of recommendations, actually we need to best understand their preferences in order to kind of to help kind of decide what's best. So if that's the kind of the first yes but, another common yes but is, well, there's just not enough time. Yeah, there's not enough time to go through all the options with people or look at the evidence or discuss the evidence. And I guess to that I would be saying, well, this is a really important investment of time, and that we need to perhaps spend a little bit more time going through kind of options, and we need to have that conversation with people that in the long term this is likely to both kind of save time, but also people will be making better decisions and will be getting the kind of the best care for them kind of the first time round. There are, of course, a number of ways which we might kind of help kind of make things more time effective in terms of sharing information kind of via kind of the internet and kind of written materials, but also kind of in the course added to in the conversations that we kind of have with people. Then the kind of the final yes but that I'm going to kind of highlight here now is that, well, actually we're already doing shared decision making. And my experience of this, both myself as I've learned over time and kind of observing others, is that, well, we might think we are, but actually are we? Yeah, and to be kind of very kind of mindful of that, and at what point are we actually kind of helping to kind of make decisions and share that kind of with people, and are we doing that throughout kind of the practice that we're offering? I mean, one of the key things that we need to remember is really making sure that we're evaluating this and asking for feedback as we go. Yeah, and actually kind of sort of checking out with the people with whom we're working that they're feeling as involved as they can be, and asking about their yes buts as well. And if we are already doing shared decision making, if you are already doing shared decision making, then that's fabulous. Yeah, I'm really kind of pleased to hear that. But let's look at how we can maybe make that kind of consistent and high quality practice across all the decisions that are made, or as many as kind of possible, both kind of simple and complex? And how do you document the kind of the fact that this is what you're doing? And can you share this learning? Can we share this learning together in kind of weeks like this and in other settings as well? So if those are a few of the yes buts, one of the things that I kind of want to highlight is that kind of shared decision making isn't a one-time thing. It isn't something that we simply do at the start of either a course of therapy or other kind of psychological practice. It's something that we need to keep in mind moment by moment. And in particular, also thinking about kind of endings and how kind of shared decisions around endings kind of are made together with the people with whom we work. So kind of finally, just to say, if we're going to be committed to evidence-based practice, we absolutely have to be committed to shared decision making. And we can all learn from the kind of the further conversations happening in this symposium, definitely myself included. Thank you.
On to the next slide, if that's all right. So, shared decision making. I think it's quite complicated, although it sounds very straightforward. When NICE was bringing its guidance together, it found that 80% of clinicians in the NHS think that they have shared decision making, but 60% of the patients that they researched found that felt that they didn't have shared decision making. So there is a definite difference between what clinicians think are happening and what patients think is happening. And since the Montgomery case some years ago, it is actually a requirement that any risks and any reasonable alternatives to treatment should be discussed. So that's the NICE perspective. But actually there's something really important here, and that's that it's really complicated for members of the public in England. We know that there are many people looking for psychological therapy and that there are long waiting lists. And the PPN has worked to try and increase the workforce along with other psychological professionals so that those needs for care and psychological care can be met. Can we go to the next slide, please? So I've been thinking, what is important for psychology and psychological care? And for me, it's definitely the most important thing is about compassion, psychology provided with compassion. And then I was thinking, well, how do we know that compassion is actually happening? And for me, this is very much about people being respected. And I think a really important part of respecting people is enabling them to make decisions about their own care and what they think is important in therapy. So I think compassion is demonstrated through giving people choice, through giving people information, through giving people the opportunity to undertake their own decisions in line with their own preferences. Could we move to the next slide, please? So here are some resources about shared decision making that will help you to think about that in more detail, because I think it does need more thinking about. We can see from the evidence that there is that difference between experience of people who use the NHS and people who are providing services in the NHS. So can we move to the next slide? So what does shared decision making mean? Shared decision making means that people can decide how much they want to share in decisions. And Nick referred to the fact that some people don't want to make those decisions, or maybe just have never thought that that is a decision that they can make. It means having a conversation. I think this is where it's perhaps difficult for hard-pressed psychological practitioners who are having to meet deadlines to think that they need to do something different. So having a conversation, which I think then leads to people feeling listened to, and that's not just the person, but the families as well need to be listened to. And people feel happier with their care because they are making choices about their care, because they're making decisions about their care, and this leads to better outcomes. And I would say that this is because the person has more control. Can we move to the next slide, please? I think it's a different way of working. If the evidence suggests that people are not experiencing the opportunity to take part in shared decision making, then something different needs to happen. I think for me, one of the most important things that this means that there are engaged and informed individuals and carers. So maybe it means going right back to the beginning of thinking about how psychological care is delivered and really considering what engagement with people who are using the services means. I think also from a lived experience perspective, we want to see joined up care. So this is not just about the joined up care, the care that's offered by the psychological profession, but also that the care offered by the GP or the other members of the secondary community team or the inpatient team. All of this is joined up so that the person isn't left with only part of the information, only part of the picture. And this needs to be supported by organisational processes that allow for the fact that people need time to be able to be informed and make those decisions. And it all needs underpinning by commissioning. So there is quite a lot of difference that needs to happen in order for people to be feeling that they can make decisions about their own care. Can we move to the next slide, please? So how can you tell that you have shared decision making? I think you have to be asking the person if they want to involve family members, friends, carers and advocates. And for me, that's not something that I personally have experienced. If so, they need to be included. And it goes back to that idea of engagement again, actively engaging in a discussion about the decisions that need to be made and finding out what matters to the person so that you can give the information to the person that they want to hear, not what matters to the professional, because we've seen just from that small piece of evidence at the start that those two things can be quite different. Ask the person to think about decisions about their care, because sometimes when we're so unwell, it's really difficult to make a decision and we do need help. And I've experienced that myself. But being asked about whether I want to make a decision is the beginning of a journey around taking control of my own mental health. And make sure that information is easily available so it can be remembered. Can we go to the next slide, please? So I think we are all part of the jigsaw of psychological well-being. And one of the missing pieces of the jigsaw has been the involvement of families, friends, neighbours, the important others of the person who needs to access the psychological care. Can we go to the next slide? I think it actually means a fundamentally different way of thinking about things. It means being really welcoming to the person's family or their friends or their supporters. And we hear from people that that's still something that the mental health services across the country are sometimes struggling with, and that even the triangle of care is not always being thought of by clinicians, that triangle of the carer, the clinician, and the person who's receiving the services. Can we go to the next slide, please? So I think it's about being given time and choice. And I think if you're not used to making decisions and you've gone to your clinician and you hope that they're going to provide you with a cure, and to be quite honest, I think that that's how I started off when I had my mental health difficulties. I was looking for a cure from a clinician who knew what they could give me, and they could give me something that I didn't have. But being given time to think about those choices, I think, is something that gives us power, and it's power to take control. And I do have a fundamental belief in us having control of our own recoveries and being able to make choices that are in line with our preferences for living the life that we want to lead. So I think shared decision making is not just about that first meeting around what treatment somebody should have. It's also about shared decision making during treatment and at the end of treatment. Can we go to the next slide? So what do the NICE guidelines say? They say explain the healthcare aims of each option and have a discussion about how this fits with the person's aims, priorities, and wider goals, and openly discuss the risks, benefits, and consequences of each action. I think this is something that I haven't ever experienced when I've sought psychological care. So for me, it would be a different way of working. And I'm not sure how I would receive it. I think I'd be quite surprised. So maybe there is something about trying a new thing here, even though psychological professionals always consider that they're working collaboratively. Shall we go to the next slide? So clarify what the person hopes to gain from a treatment or intervention and discuss any misconceptions. And I am sure there will be misconceptions. In my wider work, we've recently done a small piece of discussion work around our ideas of who the psychological professions are. And we found that we didn't really know very much. And if we don't know who they are, we probably don't know what type of care they're offering. So there are some misconceptions and information that needs to be given. So it's about supporting the person as they're considering options, delivering information in manageable chunks, and you can see a link here, and checking that the person understands the information, and you can see some information here so that you can think about those skills that you already have if you're a professional, psychological professional, and think about where you might be able to expand those skills. And even as I'm saying that, I'm thinking, oh, it's really complicated, isn't it? Because I know that psychological professionals are stressed by the demands that there are within the NHS. But I'd also say one of the great things about being part of the NHS is that opportunity to do something different, to refresh ourselves and think about a different way of doing things. And I think this is one of those opportunities. Can we go to the next slide? So I think the idea of really implementing shared decision making, of helping us as patients or family members to realize that we have more control than we think, is actually a way of transforming services. I think it has the potential to transform services, psychological services for both individuals and families, but also to move away from an NHS that in the past has been more about doing to people rather than working with people. Let's move to the next slide. So I'm not sure what level you think you're at when it comes to shared decision making. Maybe these presentations this morning will give you an opportunity to pause, refresh, and think differently. And if you are a member of the public, I hope it's helped you to think more about what you want from your care in the NHS. Next slide, please. So it's about recognizing that decisions are being made. And actually, I think this is one of the big problems, that actually half the time, psychological professionals are not aware that they're making decisions. They're so used to making decisions that perhaps those small detailed things that are happening at the beginning of therapy, during therapy, and at the end of therapy, that they assume should just be happening, aren't being recognized as decisions that the person could be involved with. Most importantly, it is about clinicians knowing and understanding the best available evidence so that the person and the family can hear that and make informed decisions. It's about working together, and it's putting the patients and possibly their families' preferences first. Shall we go to the next slide? So it's all about a balance between the patient, the therapist, the family, and the carer. And I think in the past, that balance has not been quite where it needed to be. So perhaps one of the things you can take away from this morning is thinking about that balance, the balance between personal and family and clinician power, and how that can be worked through to enable a better outcome for people who use services. Can we go to the next slide? So it's about giving people the power to decide. Next slide, please. We are all part of the jigsaw of psychological well-being, and we can be, those jigsaw pieces can fit together where people are given the opportunity to share in decision making, where families, supporters, neighbours, friends are included, so that the jigsaw pieces all fit together and the best psychological care can be given to people who want it. Thank you. Could we go to the next slide, please? So thank you very much. We're going to go on to something different now, and you're going to hear from Paul. So I won't introduce this anymore. I'll just hand over to the host, and we'll hear from Paul. So we welcome now Paul, not his real name, who is an expert by experience. Thank you for joining us today, Paul. And I wanted to just start off with this sentence that you provided me with. NICE guidelines state that for people receiving care, the care and support you receive should be based on your needs and what matters most to you. Would you like to comment on that?
Yes, thank you for having me, Laura. Initially, my perspective on this would be is who decides what these needs and their priorities are, or how do we indicate what these needs are? Without inclusion and shared decision making, we will only get one-sided view of the issue. For instance, the care we provide needs to be holistic. It should be a 360-degree view of the person, individual, or service user we're caring for. In relation to gaining access to psychological therapies, for example, in good time being complicated, I'd say, yes, definitely that is an issue. However, it's only going to be as complicated or simplistic as we work to make it. For example, or for instance, who should have access? When should they have access? Do we have available professions ready to meet the demand for this access? These are the type of complications that need to be reconsidered. With relation to a crisis team, a decision is usually made within days, if not hours, regarding the patient or service user's needs and delivery of service meeting these needs. Why is it not the same for access or psychological therapies in good time?
So a really important question there. I wondered if you wanted to make some comment around the need for psychological professionals to be compassionate.
Personally, I believe without compassion, life in general can become quite empty. However, it is important to know as professionals where to draw the line between compassion and overprotectiveness, and how to transfer the skill onto the service user as well. What I'm referring to is goal setting in the early stages of intervention, and also encouraging the individual service user to effectively and safely be able to gradually challenge themselves, to be able to empower themselves to better their well-being, therefore taking control of their own situation in the long run.
Thank you. So I think also you wanted to talk about the importance of psychological professionals considering families and carers.
Of course, this is a very important point to highlight. I mean, I'm sure I'm not the only person who shares this view, but as professionals or carers or family members or even the service user, there is a duty of care we hold towards each other. Maybe it seems more so on the professionals than it is on the other groups within the triangle. However, this ought not to be the case, hence the term shared decision making. From a professional perspective, it may make life easier had there been more relaxed legislation in relation to data protection, for example, when discussing certain aspects with carers or family members of the service user. How about, for example, if we were to relate this scenario to a safeguarding issue, whereby data protection protocol had to be broken for the safety of the service user? There'd be no issue. Why does it then not transcend over to the carers or the family members of the patient or service user? In some cases, this may be the difference between someone relapsing or being sectioned for years or recovering and balancing maintaining their own well-being in due time.
Thank you, Paul, for sharing those really important questions and points. And I'd like to say thank you for taking part today, and we can stop the recording.
Thank you very much for having me, and it's been a pleasure. I hope I've been of help.
Thank you very much indeed. So we're going to move on now and to hear from Jeff. So I'll hand over again to our host for that. So we're going to welcome Jeff now to our morning's activities. So Jeff, would you like to say something about yourself?
Yes, certainly, Laura. I'm an expert by experience with the Sussex Partnership and the Salomons Clinical Psychology course. I have a history of poor mental health, and I'm also a carer for my son who has a learning disability and struggles with his mental health.
Thank you. So we're discussing shared decision making this morning, and I wondered what you would like to say about it, having had a look at the NICE guidance and us having had a conversation about it. What would you like to say?
I think, in my experience, I think there's probably two barriers to shared decision making, which are knowledge and choice. So in thinking about that, I've thought about each sort of stage of, or potential stage of treatment. And often the first sort of decision making stage is when people go to see their GP, who may well prescribe them drugs. I've found, from my experience, that doctors' knowledge of talking therapies is generally pretty poor. And I think the psychological professions need to work on educating other professionals better so that they can explain the choices better to the patients.
So that's interesting, because it sounds like you've had experience that you've wanted psychological therapies, but you haven't necessarily been able to access them.
Yes, and I think perhaps my most recent experience with my son and his mental health is having been to his doctors several times and having been offered antidepressants. I discovered just by using Google that there was a specialist team in his area which treats people with learning disabilities who have mental health issues, which the doctor hadn't put us onto. And we self-referred my son to that service, which has been excellent for him. So I think there is that's an illustration of, I think, the lack of knowledge of GPs of what is actually available in terms of talking therapies in their area.
So there's really something about joined up services and the different parts of the NHS knowing about the other parts of the NHS, which seems really important.
Yes, and I think the other thing about that choice, giving people that choice, is, are those choices really available? I mean, I can understand that maybe GPs reach for drugs quite readily because perhaps they know, or they think they know, that talking therapies aren't available, certainly straight away, if at all. So I think it is
Yes.
about, the whole business of having choice and joint decision making does rely on actually there being those services available in an area to provide that choice.
Yes. So I think you wanted to say something about the patient not being well enough to be involved in shared decision making. Would you like to say a bit about that?
Yeah, I think very often, I suppose, when people first go for help with their mental health, they may not really be in a position to, make decisions which I suppose are in their best interests. And I think that's where particularly carers, should be involved in those discussions. I think it all depends on obviously the level of knowledge that patients and carers have. But obviously, once professionals can explain the choices to both patients and carers, then carers can help them make that choice. I feel particularly, I suppose, nervous when I get involved with my son's mental health, and he's assessed, and I'm also on the Zoom calls as they've been of late. That I don't want to interfere in that assessment. But on the other hand, I obviously have 30 odd years of history knowing about my son's mental health. So it's quite difficult for a carer to strike that balance between allowing the patient to say what they want to say and also providing sufficient background so that the professional can, come up with the right diagnosis.
So it's not just the professional who needs to think about the balance in relation to the person and whether the family or carer who are involved in the care. It's also the carer who's doing a lot of thinking
Yes.
by the sound of things.
Yeah. And then I think there is also then going into maybe the treatment stage, I think quite often, maybe because of confidentiality reasons, which I perfectly understand, there is often a lack of feedback to carers. So, a patient is going through treatment and, is having regular sessions with the, psychologist, and the carer gets very little sort of feedback, which they could use to assist the process. But
Yes.
actually, I think, that is often lacking. You feel that once, you've made quite a lot of effort to get treatment for your relative, that you're almost sort of sidelined and no longer considered as part of that, part of the treatment, which I think,
Yes.
could be a huge benefit. I'm certainly talking to my son about, the sessions he's had. I think it's been very helpful for him and for myself and my wife to understand, what he's discussed during those sessions so that we can support him.
Yeah. So it's a joined up approach to therapy.
Yeah.
So I'm noticing there are a couple of other things that I have here to ask you about. One is something about rapport with the therapist, and also your experiences around COVID and what difference that has made.
I think I'm I suppose slightly concerned that I think there seems to be, perhaps a belief within the psychological professions that a psychologist should be able to treat anybody, whereas actually, certainly my experience, it does make a huge difference that the psychologist can sort of walk in the shoes of the patient. And again, referring to my son's experience, he was fortunate enough when he was receiving treatment to be treated by a male psychologist of a similar age to him, who he really built a rapport with, and a rapport which he hasn't in the past built with people of different age and gender. So I think it is important that part of the choice is for patients to be able to say, and for psychologists to be able to say, this isn't quite working. Perhaps we should try someone else.
Yes. Yeah. So I think you wanted to say a little bit about the use of jargon and language.
Yes, I think, even though I've been involved as an EBE for a few years now, still some of the jargon confuses me and I have to go away and look things up. But I think equally for patients, prospective patients, terms which are, commonplace for psychologists like CBT may not be understood by patients. I think naturally patients are perhaps a bit reluctant to ask because they don't want to appear to be stupid, and therefore that it's difficult to sort of share that knowledge because the professionals may not know how much the patients understand. Again, I suppose an example of my son, when he was being assessed, I was discussing with the psychologist that he'd had ACT therapy previously. Well, my son had no idea, I don't think, what ACT was. I didn't want to embarrass him by asking him during that assessment, but that's just an example. And I've also noticed that there are other examples where trainees that I've worked with on Salomons have used terms such as formulations during treatment, which I don't think perhaps many patients would understand. So I think it's just a matter of being aware of the fact that you don't want to use too much jargon that people don't understand.
So Jeff, I think you wanted to talk just a little bit about how you'd experienced COVID had impacted services.
Yeah, and I think this goes to the general point about choice, because certainly the experience I had with my son, just I suppose almost by coincidence, we managed to get my son referred for some psychological therapy during COVID, but his issues weren't particularly connected with COVID. He coped actually remarkably well during the pandemic. But I think there's a lot of good resources gone into the implications of COVID and the effect that's had on people's anxieties. But I think we just need to remember that people should still have other choices that they can make about treatment. Yeah.
So I think we've come to the end of our time together, but you've got some key messages. So would you like to say what those are?
Yes, certainly. I think, yes, just to sort of really summarise our conversation, I think one of the main things is that the patients need to have the choices they have explained in a language that they can understand, so that they can actually make proper choices. The other thing is you need to be realistic about what treatments are available. There's no point giving people a choice of a treatment where there is no availability. And also, I suppose, if the client isn't responding to treatment, you need to reconsider the options for the client, whether it's a different treatment or maybe a different therapist.
Well, thank you, Jeff. It's been good to hear your perspective on shared decision making this morning. So thank you very much for taking part today.
No problem. Thank you.
So thanks to Jeff for taking part in our morning session. How do we enable psychological professionals to share decision making? How do we enable new psychological professionals to think in a different way where patients really are being offered choices about their therapy? I think that this can take place during psychological professional training. So one way is to model this. We're going to hear now from both myself and Dr. Rachel Terry talking about an example of involvement in therapy and clinical training. So this part of the morning, we welcome Rachel Terry. So I'm just going to ask her to introduce herself.
Hi everyone, I'm Rachel Terry. I'm a clinical psychologist and also the admissions director on the Salomons Clinical Psychology Training Programme. When I've worked clinically, I've worked in forensic mental health services and acute inpatient wards.
Thank you. And I guess also I need to slightly reintroduce myself at this point, because I'm speaking from my lived experience of this part of the morning. I became involved in expert by experience work through being a member of a mental health service user group. And then I became coordinator of service user and care involvement work at the Salomons clinical psychology course. So Rachel and I worked together. So Rachel, I wanted to ask you about a piece of work that we did and how that came about when we provided some training together for the first year clinical psychology trainees. So I wondered if you could tell me about this piece of work.
So as part of my role, I organised the CBT teaching for the first year trainees. And although we know that many of our trainees will have had CBT therapy themselves, not all of them will have done so. So I was really keen as part of that block for our trainees to have experience of hearing from somebody who has received CBT about what that was like. I was also very aware that everyone's experience of CBT might be different, but I thought that that would be a good starting point. So in your role as coordinator of service user involvement, we spoke together about how we could think about including that within the teaching block, didn't we, Laura?
Yes, so it was a really interesting piece of work for me. I spoke about my lived experience of therapy with a CBT therapist, and we recorded something. I guess one of the things we did was sit down and talk about what questions we both wanted to ask, but with the thought in mind that it will be Rachel who will be asking these questions. And we set up a camera in a interview room, and I guess we left the camera rolling for quite a long time, maybe over an hour, whilst I talked about the things that I thought were important from my therapy that will be useful for a trainee to talk about. So that's not all there is to this piece of work. We didn't just do a piece of video, we did something else as well. So Rachel, I wonder if you could say how this piece of video was used in the training.
Well, firstly, just to say why we decided to do a video was because we thought that then the resource could be used for future years as well. So if we had it on a video, we could use it for a few cohorts in a row, so that would be good. And also there was a chance to kind of stop recording for a minute, restart, so there was a bit more sort of freedom than there might have been, a bit more safety than there would have been if we'd been live in a room. And we, as you said, Laura, we thought together a lot about what kind of things would be useful for the trainees to hear, also what you felt comfortable sharing and what you didn't, and we were very clear that we weren't talking specifically about your difficulties and what led you to the therapy, but more about your experience of the CBT and what was helpful or what was challenging. So that was the first component of the task. And we asked all the trainees to watch that video, but we asked them to hold in mind specific questions while they were watching that video, which you and I had thought about together beforehand, and for them to answer those questions and send the responses back to both of us. And in part that was to check that they were doing the video and doing some thinking about the video, but it was also important for us to get a sense of what they were taking away from it and learning from it. And so we were keen for both of us to be looking at those responses to get a sense of that.
So that's a really interesting piece of work for me to be involved in, because I see all the trainee responses and I reply to all the trainees, often picking out things that I think are important from a lived experience perspective, and they know that it's a lived experience perspective, it's not a clinical one, so it doesn't address the breadth of what they are sharing, but those things that are important to me, having been the person in the video. So one of the things that often happens is that, and can be a problem in involvement, is that trainees respond in a way that they think that they are addressing my problems rather than addressing the experience of using the therapy. But so it can be challenging, as all lived experience work can be challenging, but I find it a really life affirming experience, actually, to read the responses of enthusiastic trainees who are interested in hearing what it's like to experience having CBT therapy. What do you think the response is from the trainees, Rachel?
Well, I'm always impressed with how thoughtful they are and how much they take from the material. And so it does reinforce how much of an important learning task it is, and how important it is to hear from people who have been in the other chair experiencing the therapy when they're delivering therapy themselves. So I think it's a really key component of the block. But one of the things I was interested in, Laura, was how you think what we did together that made it feel safe for you to talk about something so personal. What made it feel safe for you to open up in that way?
Well, I think this is where I really come back to the idea of shared decision making. So it really felt that I have been given control. So that we set up the boundaries around it before we started. So there were certain things that I didn't want to talk about, and that was respected. The idea of videoing and recording gives more power, because you can always stop a video or stop a recording. And also I felt very supported. So if in the responses from the trainees there was anything that was difficult, I was able to come back to you or another colleague and talk about how I should respond in a way that was helpful to the trainees, because all involvement work in training has as its aim the learning of the trainee, and sometimes that can be difficult for the EBE, because those two things can sometimes not mesh together in an easy way. But I really also wanted to talk about what was in the video, and again, this is really about shared decision making. This was such an effective piece of therapy for me. And the reason it was an effective piece of therapy was that my therapist was really interested in exploring with me the idea of shared decision making. So he was particularly interested in going to the thing that I felt was most important for me in overcoming my anxiety, because I had become so anxious. That's why I had been referred to this therapy. And the anxiety was actually that I was throwing up when I was wanting to throw up when I was in the car and having to stop the car when I was driving. But actually what the goal ended up being for this therapy was managing to have a cup of coffee in a coffee shop. And I was just so impressed with the way that the therapist moved from what was an obvious presenting problem, if you like, I think that's what it's called, to something that was so important and integral to my life. That was the enjoyment of drinking coffee, and I have a coffee, I really enjoy it every morning, but also the social aspect of going to a coffee shop and actually being able to order a coffee without wanting to throw up. So this therapist really, for me, demonstrated what shared decision making was about. And in some areas, he wasn't as quite on the idea as he might have been, because I remember him saying, let's do some sort of timeline. I'm not sure what it was now. And and I said to him, can I hold the pencil? And it was really interesting, because for me, this is an example of not necessarily the therapist identifying that there's a decision to be made. And the decision to be made there was who was actually going to do the writing, who was actually going to do the drawing. And I really found it empowering that I had control over the pen and the pencil and could write what I wanted to write. And we just sat together at a desk to do that piece of work. So for me, this whole piece of work with you, Rachel, really demonstrates the power of shared decision making in involvement, shared decision making in training, and shared decision making in the actual therapy. And the therapist being flexible enough to learn shared decision making as he was going through that piece of therapy with me. So I guess I'm just thinking as we come to the end, Rachel, whether there are any important things that you would like to say about shared decision making. And the fact that NICE has brought this guidance out for everybody this year, and what your take-home messages might be.
There's a lot in there that I could say. And as you were talking, it was making me think of the ethos of CBT therapy, which is meant to be very much around shared decision making. So at the beginning of therapy, a key part of CBT is developing shared goals, which is what you talked about, and finding that particularly helpful. But also within each session, having a shared agenda or plan for the session. And you talked about also having opportunities within each session for the person receiving the therapy to do their own writing or take ownership of tasks. And so I'm really pleased that your therapist was being thoughtful about that, because that is one of the key principles of CBT, collaboration. And it's nice the way that you've linked together the importance of collaboration both within therapy but also within training, and sort of having that consistent thread through both, which I really believe is really crucial. And we also know in terms of outcomes for clients, where clients feel that their preferences, their choices are considered and are given value and taken account of, people are much less likely to drop out of therapy and more likely to make changes than if they're not given a chance to express their preferences. So I don't know if that captures my take-home messages. My take-home messages are expert by experience involvement within a therapy and within training is crucial, but that needs to be not a tokenistic thing. You and I did a lot of thinking and planning about this teaching task beforehand, and every year that it runs out, we think together about it. So it's not an easy option, which might be why there are nice guidelines now, because it's something that takes time. It needs to be factored into clinical services and training, but is very important that it happens.
Thank you. I guess my take-home message is just about how when you have a mental health difficulty, you lose your own power, but being given choice gives respect to a person and enables us to find power through the opportunities of being given choice and being given the opportunity to share a decision. So I guess that brings us to the end of our time. Just to say thank you very much, Rachel, and we'll pause there. So thank you very much indeed for listening to our different recordings and live speakers this morning. I think I'm going to hand back over to Adrian now, if that's all right.
Thank you very much, Laura. And I just want to say a huge thank you to you, Laura, and to Jeff and Nick and Paul and Rachel for your excellent presentations and conversations that I think we've all been able to learn so much from. So we're going to move now into the question and answer part of the session. And so we've been receiving some really interesting comments and questions through the Slido. So please do keep those coming and keep voting on the questions and comments that you're seeing, and we'll pick up as many as we can now. So we're going to move to a panel, which will be myself and Laura and Jeff, and we'll pick up as many of these now as we can. So I'm just going to start, Laura and Jeff, with a question that's come specifically for you, obviously also for Paul, but Paul not able to be here live today. Could you share what attributes you find most important to have in your clinician?
Ooh.
And I'll come to you first, Laura, if that's okay.
Okay, I actually think that kindness is the most important thing. And I think there are psychological words for that, like warmth, but kind is really important, and that gets over a lot of problems. If you can tell that your clinician means well for you, but also I do want a clinician who knows the evidence. So I think that that's really important. Going right back to that first video, I'm the sort of person who would say, well, what does the evidence say about depression? You know, and that's really helpful because that helps me make the decisions.
That's great, thank you. Jeff, anything you'd like to add?
Yeah, I think I suppose for me, it's perhaps about active listening is very important for me, to actually believe that the therapist is actually, is present and listening. And I suppose it's one of the issues perhaps I've had over the pandemic with Zoom and what have you. It's not always possible to tell, if you're in the same room as someone, you can tell whether they're really paying attention, but sometimes over Zoom you hear them typing and you think, well, I'm not quite sure what's going on here. So, it's that sort of, being present. And I suppose the other thing is, I suppose I want which I alluded to in my discussion with Laura, I suppose I want someone who I feel can walk in my shoes, who understands my life. And I know that can be very difficult because, quite a lot of, from my experience, quite a lot of people who have mental health issues come from a sort of socio-economic background which is very different from the therapists, and therefore that can be very difficult. We all know there are issues with ethnicity and predominance of largely sort of female, well-educated psychologists, and patients who aren't that similar.
Thank you very much. Very, very helpful insights. And what you're saying, Jeff, actually links to the next question which has come up, which it's really more of a comment than a question, but it would be useful perhaps for us to just reflect on it. Involving service users in communities where English is not the first language, and also where communication challenges exist, for example, people with disabilities, is key. So I think we'd probably all agree with that, but I wonder if what our reflections are as a panel on how we think that should be addressed.
I think as a carer for someone who has a learning disability, I think the key to me is involving carers or family in the treatment, because they can act as interpreters very often. I think in a perfect world, the psychologist would talk to people in exactly their language, but I think that's not possible. But you can use family members to be that sort of intermediary.
Thanks, Jeff. Laura?
I think there is something really important about outreach, and it's about reaching out to members of the community to communities who are interested in making those bridges between the psychological professions and who those communities are. And I think it's relevant in relation to young people. How do we communicate with young people? There are new and different ways about communicating. So I think there needs to be actual outreach work. But I'm wondering what you think, Adrian.
Yes, I suppose it's important to make the point that psychological interventions and psychological therapy can be delivered very successfully through interpreters. So it's not actually essential for the therapist and the person receiving therapy or the other intervention to share the same language. But services obviously need to make significant provision to allow for this, because sessions take longer, interpreters need to be booked well in advance, and we need to make sure that that the specifics of sort of language and dialect are taken account of. So I think that's really important, is to know that that is a service that should be available. And if there are settings where it's not available, then services should really be moving rapidly to make sure that it is. So I'm going to suggest we move on to the next question now, which I think is a very interesting one. Could the PPN and the family of psychological professional bodies lobby NICE to ensure patient decision aids are produced alongside every guideline and guideline update? And I don't know what you guys think. I think this is a really excellent idea. Do you want to comment on that first, and then perhaps I can say something about what I think we might be able to do about it?
Well, I absolutely think it's a really good idea, because I think, in my mind, I have this vision of transformation. And I think things are changing. If I think even 3 years ago, I think about how my own mental health is thought about. But I think it would be part of that process of bringing in a different way of thinking about how both the client or the service user and their family members are brought into the discussions about what they prefer. So yeah, I think it'd be really good.
Yeah, I agree completely, Laura. And I think also, perhaps moving on from that, I think, you know, one of the barriers to getting treatment is that the services which are available in different areas are completely different. So, you know, I'm in Sussex Partnership. My son lives in Kent. It's very difficult to find out how it works in Kent. I've got, you know, from my own experience, I know how things work in Sussex. But I think there is a, you know, there needs to be a sort of consistency across the country as to, you know, how people find help.
Thank you. Yes, and I mean, I would share your enthusiasm for this and your call for consistency. So the guideline itself does ask that patient decision aids are used, and it also specifies that patient decision aids should be subject to sort of strong governance processes to ensure that they're sort of fair and correct, which makes perfect sense because we know this is a sort of highly debated area as to what the evidence shows, etc. So I think this is one that we should sort of all of us be taking forward and thinking about as a sort of standard that should be applied from here on. So obviously the PPN itself doesn't set policy, but we'll certainly engage in conversations about this so that we can support where we can to move this forward. So thank you for that. The next point is really, again, not a question, but we may have some reflections on it. Change involves not only a persuasive argument and other people listening, but also them having the willpower and money to achieve tangible change. So this question came in actually very early in the session, and I think what the point here that I'd just like us to reflect on, I suppose, is this isn't all about the individual. It's also about how sort of resources are flowing in the system that can make change happen. I mean, I would absolutely agree with that and think we need to be working to ensure that resources flow in the direction of change and shared in this sort of way towards shared decision making being the norm. But any further comments, Jeff, Laura?
I think the only comment I'd make is I think, you know, shared decision making does rely very heavily on actually having a choice. And you only really effectively have a choice if those services are available in your area. And, you know, if a lot of money, resource has been pumped into one particular therapy, it means very often, certainly from my own personal experience, that that's what you're offered. And if you refuse that, there's nothing else on offer.
Yeah. I think from my perspective, there's something about the balance that's required. When you have shared decision making, I think the balance transfers, that balance transfers more to the person, and certainly it needs the inclusion of the family. And I do think that there is something about not only the willingness of the individual clinician to be contemplating what that balance looks like, you know, when they go and meet somebody today or tomorrow, and moving that in that direction of shared decision making. But it is a whole systems change that is needed. And I guess this idea of suggesting to NICE that those tools are available is part of that whole systems change.
Yes, and I think the guideline itself is actually pretty clear that it's whole systems change that's needed. So we do have something here that's been through a very sort of independent and formal process that we can use to try and influence change in the system. So the next question, I think, Laura, you've partly picked up in your conversation with Rachel that we've heard, but interested in further reflections on this, and perhaps it might be worth, Laura, saying something about the sort of the work that's planned around involvement of experts by experience in psychological professions training. But the question is, how do you think clinicians can better be trained for shared decision making? And I'll come to you, Laura, first on this one.
Well, I do think that it is a significant task, because I think it's a culture change that's needed. I think that modelling involvement and the shared decision making in involvement in training is a way of enabling trainees to think differently about how experts by experience, people with the lived experience of health challenges, are regarded by professionals. I think simply having a place at the table of training makes people think differently. So I do think there is something really important about involvement in training. And I think the example of what is it like to experience this therapy that you are being trained in, that's even if somebody is training in a therapy they've already received, because they're part of the NHS system, they're privy to knowledge which people from outside the NHS system don't have. And I think that insight is really a valuable thing for people to have. So I do think that there's something about involvement in training is central to this.
Yeah, I think I'd add to that. And so I think, certainly in my experience, I think it's very valuable for trainees to hear from people who have lived experience, and particularly people who've come through that lived experience, because very often they're treating people in crisis who aren't in a position to reflect on the treatment they're getting. They're just receiving treatment very often, whereas certainly, I mean, the work that Salomons do, with the experts by experience, being involved in the advisor scheme with trainees, and also I've been involved in clinical vivas and interviewing first years. I have to say that, as an EBE, you go into these roles with some trepidation, because you're always concerned about whether there's a bit of tokenism there, or whether you're really going to be listened to. And I have to say, my experience has been overwhelmingly positive. With all the EBE work I've done, I have felt that my views have really been valued. So, and I think it's been of massive benefit to trainees that I've spoken to.
Thank you both very much. Go on, Laura.
I was just going to say, I suppose the other thing that I'm thinking about is, that need for people to keep on reflecting, keep on thinking, keep on reflecting. Don't feel that, it's so easy to just keep on churning day by day, especially when there are real stresses around a job. But that idea of taking a moment to reflect and have a think and reset is I think essential for any change to occur.
Thank you. And I suppose what I would add is that from the work that you and I have been involved in, Laura, in the National Psychological Professions Workforce Group, we are now expecting all psychological professional trainings commissioned by the NHS to have expert by experience involvement in the a whole range of the processes of that training. So both delivering, planning, assessing, etc. And we're also now commissioning all of that psychological professions training based on there being involvement in it. So I think we're sort of really pushing in this direction to ensure the involvement is there. I think we need to obviously make sure that shared decision making is a key part of that contribution that can help push this agenda. So probably time for a couple more. This is an interesting one. I wonder if a sense of involvement actually improves outcomes ultimately, in which case it would actually be a very time efficient treatment approach. So I don't know if you have personal experiences of this that you'd be interested in sharing, or knowledge of the evidence. It's a shame Nick's left, because I'm sure he could say more on this, but I'm happy to comment on the evidence in as far as I understand it.
Yes, I think Rachel also brought that forward. I'm assuming that that's involvement in shared decision making brings better outcomes. Yes, so it's not an area that I'm completely familiar with, I have to say.
And from your own experience, either of you, does this ring true?
Yeah, it absolutely rings true. When decisions are taken away from me, I tend to move towards, I want to say the lowest common denominator, which is is the one that's my internal dialogue, which is, I'm no good at this, I can't do this, I'm feeling too ill. And when people take away or don't include me in decisions, that's what I default to. And I think it actually therefore pushes against recovery, whatever that looks like. So that's my personal experience.
Thank you.
Yeah, I would say that my personal experience, I think for my own mental health, I don't think I've really witnessed shared decision making, to be honest. Whereas perhaps through necessity, perhaps more with my son, I've been more involved, and I think there has been a much greater degree. And I think maybe that's because, you know, psychologists, difference between dealing with adults and dealing with people with learning disabilities is a slightly different approach.
Thank you. And I think, I mean, what I would add from my understanding of the evidence is that there is strong evidence that offering choice, real choice, does impact outcome. And so we absolutely need to be offering choice, as you said previously in the session, Jeff, realistic choice that actually exists. But that if we are able to offer that, then we know that outcomes appear to be better. And that isn't just for psychological approaches or therapies, but in fact, across the board. Offering choice of physical treatments also seems to, there seems to be a similar impact. So this next one sort of relates a little to what you were saying, Laura, about, you know, when the chips are really down and, you know, it may be harder to sort of engage in these processes of shared decision making. So how do we help people who struggle with their own mental health when they may not realize how well or not they are feeling? Just wondering if you have any thoughts on that.
Yeah, I'm struggling slightly to follow the thinking there, but for me, there's something about this idea of realizing that decisions are being made, and actually, I suppose, enabling somebody to just see that there are decisions and there are opportunities around decisions for them to have a choice, because some people don't see that in life. You know, I think my own mental health history has been one where I realized that there was no magic wand held by a psychological professional, and I had to start to make my own choices. So I'm very strongly in that perspective, but that's taken years for that understanding that I have a choice and I can share in decision making, for me to understand that. So I think it's about opening up the conversation. It's as simple as that. You have to have a conversation.
I think also every individual is different, and some people, I mean, it's like physical health. If you go along to your doctor or see a consultant, some people want to know all the options and they want to know all the science behind it, and they really want to get involved, and they'll go and, you know, research it on the internet. Other people just want to rely on, you know, the expert who knows best to tell them what the answer is. They don't want, I suppose some people get very anxious if they're given too many decisions to make. So I think you've really got to look at the individuals. And, you know, yes, people, when they are in I suppose, a bad place from the point of view of their mental health, find it probably quite difficult to make decisions. So I don't think you should sort of put that pressure on people to take decisions for themselves if they're not in the right mind to do so. But I think throughout treatment, keep checking back and making sure that, you know, when they are in a position to take decisions, that they have that opportunity.
Yeah,
thank you very much for those really helpful insights. As it's 2 minutes to, I think we probably need to close off the panel now. So thank you very much, and we'll move on to the next couple of closing slides now, please. So just to remind us, in this session, we've been organised around our commitment in our psychological professions vision to put people first, and we want to make this vision a reality. So we're asking you to participate, please. You're invited to participate in how we make this a reality. And this process is going to be called, as you heard in the earlier animation, the Intergalactic Bridge. This is bringing these commitments into sharp focus and showing how we're making them work for us. So please do get involved in the Intergalactic Bridge and connect with Psychological Professions into Action on Twitter. So you're going to be seeing some evaluation questions popping up on the right-hand window, and you can submit your feedback on the session using those. And once you've done that, you'll also be able to download your certificate of attendance from the session. So please remember to do that before you leave. I just want to thank everyone for being here. It's been a really great session. I'd like to thank again Laura, Jeff, Paul and Nick for your excellent, insightful contributions. Really fantastic. And we're giving you a virtual round of applause to thank you for that. Thank you so much. So we look forward to welcoming you to further sessions in Psychological Professions Week. This afternoon, the session will focus on the activity taking place across the psychological professions networks in England. And you can access any of the sessions across the week, as many or as few as you want to, just by logging into the microsite. So we look forward to welcoming you across the week.